Adhikari sir to grace this elite gathering with the welcome speech.
It's a pleasure to be here, to be standing in front of you. I would like to welcome all the speakers and the delegates from different countries, from India, Dr. Manish, Dr. Randeep, and Dr. Ashwini, all the way from India, Delhi and Coimbatore. We have Jambi and Sasim from Japan, and David Lomanto from Singapore. And at the same time, I would also like to appreciate the assemblance of Professor Manish Kapoorel, who has been one of the pioneers of surgical gastroenterology and laparoscopic surgery in Nepal. I think he deserves a big round of applause. So thank you, sir. Thank you, because you are here. You made all the way through. And yesterday we had some tough weather, the foggy disruptions of flights, but still, I think the dust must have settled down by now. And we look forward to a good gathering in the day. And so we look to explore different avenues of hernia and how progress has been made. And I think that it's going to be a memorable day for all of us. Thank you. Thank you for attendance.
Thank you so much, sir, for your wonderful speech.
Now, before the symphony of knowledge unfolds, we would like to request you all to stand up for the national anthem.
Official inauguration of the symposium.
We would like to invite Professor Shailesh Adhikari sir, Professor Rakesh Kumar Gupta sir, Dr. Suresh Prasad Saha sir, Professor David Lomanto sir, and Professor Mahesh Kapoorel sir on the stage to partake in the symbolic rite of lighting the panas.
Thank you, everyone. May the amalgamation of these elite minds and the
Suresh Prasad Saha sir to acknowledge our distinguished speakers with bouquet as a gesture of gratitude. We would like to invite Professor David Lomanto on the stage to receive the bouquet.
Dr. Randeep Wadawan sir on the stage.
We'd like to invite Dr. Sasim Paudel on the stage.
I'd like to invite Dr. Aswin Thangavelu sir on the stage.
We'd like to invite Dr. Jumpi Sibata on the stage.
Thank you everyone. Our first session of the symphony that is on groin hernia.
So without further ado, we would like to request our moderators for the session 1 to take their seats.
And the moderators are
Professor Bhojraj Nupani from Gandaki Medical College, Pokhara.
Professor Kishore Manandar from National Academy of Medical Sciences
Professor Pranil Rai from Medicity, Kathmandu.
and Professor Sanjay Paudel from Patan Hospital, Kathmandu.
Call the first speaker, Dr. Professor Manish Paisa, for his talk on systemization of laparoscopic inguinal hernia repair, TAP versus TAP, critical view of myopectoral orifice. Sir.
Morning, everyone. And at the outset, thank you, Dr. Shailesh, Dr. Rakesh, the entire surgical community here, friends. Second time in Dharan, and this time when Rakesh sent me the program, he said, you have to speak on systemization of laparoscopic inguinal hernia repair. And this is actually a terminology which I had never used, talking about groin hernia repair. So it's not TEP versus TAPP, it's going to be an overview. And what does this term systemization means? So this stays as the commonest laparoscopic procedure after laparoscopic cholecystectomy that all of us do. So systemization of laparoscopic inguinal hernia repair is based, the understanding is based on well-defined landmarks, the concept of inverted Y, identification of 5 triangles and 3 zones of dissection, and this is to achieve the critical view of safety. We've been talking about the same thing for years together. The only thing is the way it's presented now, for better understanding, it's called the systemization with this background. Now, what is the inverted Y? I'm not going to go into the anatomy. I'm pretty much sure everyone who's sitting out here understands the posterior groin anatomy. So the inverted Y, as you see in the picture, the vertical limb there is the inferior epigastric vessels. The other 2 limbs are the vas deferens and the testicular vessels. And this blue line is the iliopubic tract that runs from pubic bone to the anterior superior iliac spine. So this inverted Y and this iliopubic tract actually converts this area into 5 triangles. Why they are important? The upper medial triangle is the site for your direct hernia. The lateral is for indirect hernia. Below the iliopubic tract is the site for your femoral hernia. The red triangle is the triangle of doom, and the lateral is the triangle of pain. So this is something you need to understand well. Anatomy is something, until unless you have mastered a posterior groin anatomy, you're going to find this surgery difficult. So these are the 5 triangles. And when we dissect in this area, we dissect in 3 zones. The medial zone, the lateral zone, medial zone. Now, this is all something which I'm going to show you in videos. But why we are talking about these zones and triangles of dissection. So these are the three zones of dissection. Now to achieve a critical view of myopectineal orifice, why is it important? Because we create certain recommendations that are need to be fulfilled by every surgeon who's doing a groin hernia repair. Whether you're doing a TEP or a TAPP or an ETP, essentially the surgery stays the same and you need to follow certain recommendations to achieve the critical view. And the advantage of doing this is to standardize the procedure. Until unless you have a procedure which is standardized, you are going to have more complications, more recurrences. To reduce the recurrences, prevent complications, and improve patient care. So that is the background behind critical view of myopectineal orifice. Why we have started to talk about this? Because the reasons for recurrence and morbidity in groin hernia is being secondary to inadequate mesh size and fixation, missed hernias, insufficient dissection, overlaps, impact of experience is always there, and certain measures that you take to prevent morbidity of chronic pain. To achieve this, we have divided this into 10 essential steps to do a good, adequate groin hernia repair. And it does not start with surgery, it starts from the time you choose your patient. So when you start doing your surgeries early, you must choose the correct patient. Once you're experienced, you can do whatever you want in whatever case you want. But in your early part of your experience, take a patient who's a little elderly, thin-built. A right-sided hernia for a right-handed surgeon is simpler. The distance between pubic bone and pubic symphysis, if it is adequate, more than 15 centimeters, makes you comfortable, less crowding. Patient should be fit to withstand a longish GA because you will take a little longer time for surgery initially. When you take the patient up for surgery, make sure that the patient voids urine, or if it's a larger hernia, put in a Foley's catheter, make sure your anesthesiologist is with you, good muscle relaxation, patient is supine, arms by the side, use a 30-degree telescope to get a good vision. Now the first step of this surgery, when you do a TEP repair, now I'm essentially talking about TEP, there'll be many other talks on other techniques. For a TEP repair, to access the preperitoneal space, that either you can do it through a Verey's needle, but that's very subjective. The best way to do is the McKernan technique, which is an open technique with a skin incision to one side of the midline so that you do not injure the linea, and you go down to the anterior rectus sheath. What we also do is, this is for beginners, make a balloon. You don't have to buy an expensive balloon in the market, you can make your own balloon. It's a simple surgical glove on top of a suction cannula, which can be distended to about 100 to 100 cc in the preperitoneal space. So if you look at the hernia surge guidelines, they say balloon for beginners is always handy. So you can use a balloon dissection. You go down to the anterior rectus sheath and divide the anterior rectus sheath. Take stay sutures on both the sides. Retract the ipsilateral rectus laterally, and that's how you enter the preperitoneal space. You will enter the retrorectus space, but moment you go down in the midline, it is the preperitoneal space, and this is how the balloon goes into the preperitoneal space, and then you connect it to the Hassan trocar and carbon dioxide. Now, once you are in the preperitoneal space, this is how the space looks like. So make sure there's no bleeding, the space looks only loose areolar tissue, and this is where you will have your additional ports come in. So additional ports, you can have ports in the midline, or you can also have ports laterally. The disadvantage of a lateral port is you have to do fair bit of dissection only with one hand. So we prefer to do midline ports, but guidelines say whatever is good in your hands. So you use midline ports, and this is how the setting of the ports is. So these are the additional ports which come in the midline, and that's when you start your dissection. So you have one port that goes down in the midline, you open the space even further, and then you have the second port come in. Now once you have a good space created like this with two working ports, you are that much more confident right from the beginning of the surgery. Now, this is how you see the groin anatomy once you have the space completely dissected. And this is what we talk about, critical view of myopectineal orifice. We are looking at the right side, pubic bone. You can see the inverted Y, inferior epigastric vessels, direct hernia. So until unless you see the MPO like this, you will not place a mesh till then. Now, this is what the myopectineal orifice is. You have a so that's the site for your direct and indirect hernias, and inferiorly the site for your femoral hernia. So this myopectineal orifice needs to be dissected well and covered with the mesh. So how do you achieve this? Your dissection starts right in the midline. Your first step is to identify the first landmark. And what is that? Your pubic bone. So this is what we are talking about, the first part of the dissection, medial dissection. When you do medial dissection, you dissect the pubic bone, you dissect the space of retius, and you identify if there is a direct hernia. Direct hernia is a structure that will always cover the Cooper's ligament. If in the midline you cannot see the Cooper's ligament, that means you are looking at a direct hernia. Direct hernia is reduced by traction and counter traction. That's the pseudosac. Pseudosac belongs to the anterior abdominal wall. The peritoneal sac comes down to the floor. And moment you have reduced this, that's when you can see the defect of direct hernia. So this is the medial dissection. If there is no direct hernia, or even if it is there, you will still explore the spermatic cord to rule out an indirect hernial sac. So that's how you identify an indirect hernial sac, which is always anterolateral to the cord structures. You dissect the sac away from the cord structures. There are two ways to ligate it. One is to divide, and then you can use an endoloop. But we prefer to put in a suture first, so that there is no gas that goes into the peritoneal cavity when you divide without ligating it. So this is how you identify an indirect sac and divide it. The next step, once you have taken care of this indirect hernia, there are times there is no indirect hernia, only a direct hernia. Always look for lipomas. These are something which can get missed, and these are the patients who will continue to complain of a cough impulse. So large lipomas can be lying hidden there, lying lateral to the cord, something you must always look forward for and reduce these large lipomas. And the last step of this part of the dissection, which is the dissection in the triangle of doom, that is the second part zone of dissection, is the perietalization of the cord. So perietalization of the cord is a term that is used to perietalize the peritoneal fold onto the cord structures. You get it to the highest possible level, as you see it out here. You should be able to see the vast difference turn medially towards the bladder, and that is the extent of dissection. And once we have done that, that part of the dissection is complete. Comes the dissection of the triangle of pain. So triangle of pain is the area where you dissect, you make sure that part of the fascia on the psoas muscle is preserved. If you don't do that, you will bear the psoas muscle, and that's how you will land up injuring the cutaneous nerves. Maybe partial, but that can lead to severe neuralgia and the chronic groin pain. So that is the lateral dissection. Now once we have dissected, we have seen all the zones, you have a completely dissected space. The most economical way of placing a mesh is a flat mesh, though we have 3D meshes available. So it depends to what you want to use, but a flat 15 by 13 mesh is the smallest size in TEP that you must use, so that is another recommendation. We fold this mesh to a size so that you can handle a large mesh in a small space. So it's a folded mesh, 2 stay sutures there, and a little free margin. And this folded mesh easily goes through a 12 mm port. So once you have the mesh in space which is folded, it becomes easier for you to handle a larger mesh. So you see, just because the mesh is small, it goes in easily, it gets tucked in into the retropubic space, 2 points of fixation on the Cooper's ligament, and then what we do is we divide these sutures and unroll the mesh like a carpet. So you see, this is only a potential space. We do not have a floor or a roof. Moment the gas goes out, the mesh lies flat. So another big advantage of TP and ETP is that you need minimal fixation. If at all you want to fix laterally, it has to be high up. So you can unroll, put it up and put a fixation there, but this is purely optional. Because if you have a clean space like this is good enough. Now there are certain sequelae which are very common to groin hernia repair, and that is a seroma. To prevent the seroma, you can actually pull the pseudosac down to occlude the space. You can put sutures there. If you're doing a TAPP, to suture this sac down to the Cooper's ligament is easy. Otherwise, you can just use a fixation to occlude the space. There are times you will land up in a situation like this in which you will open the peritoneum. You cannot leave it alone. Every time you have a peritoneal tear, it needs to be addressed and sutured, because these are the patients who can actually come back with a bowel herniating into that space and causing obstruction. So if it's a small rent, you can just put it up, put an endoloop. Otherwise, you can use a continuous suture to occlude it. Last but not the least, you need to counsel your patients well. Not every time you will be able to successfully do these procedures. So you must have consent for an anterior repair in all these patients that you do. You must counsel these patients for a potential chances of developing a seroma, how it appears. You must let them know that it disappears on its own. In majority of the patients doesn't need any treatment. So a good talking and good counseling is what will give you better results in the long run. So thank you very much, and this is all about systemization.
We are going to have the question and answers in the end, in the end after everyone presents. This was indeed a very, very fantastic presentation with a lot of useful tips, especially for people who are starting to do lap hernia or who are thinking of starting it. Thank you very much, sir. And one notice I'd just like to say is, please, I request everyone to keep your phone in the silent mode or a vibration mode. Thank you.
I call upon Dr. Champe Sibaka for chronic post-operative inguinal pain. Please.
Organizing committees and participants for this wonderful symposium. My name is Junpei Shibata from Nishichita General Hospital in Japan. So I'm gonna talk about the general introduction of post-operative inguinal pain, CPIP. So first, what's the CPIP? CPIP, as you may know, is the pain lasting more than 3 months after hernia surgery with impairing daily activities. But the inflammatory healing process may last longer than this defined 3 months interval due to tissue reaction to the mesh. So systematic review authors have used pain lasting 6 months or more as a criterion for inclusion in their reviews. But now the international guidelines defines it as a 3 months ongoing pain. So CPIP definition is determined. So CPIP incidence vary due to the difference of pain definition. Clinically significant pain is said at 10 to 12% frequency, and severe pain that affects life or work is from 0.5 to 6%. It's not just mesh problem, but more complicated one. So those who try to start inguinal hernia surgery, especially everyone should know it. The types of CPIP are neuropathic, nociceptive, and somatic, and visceral, but always have mixed causes that are making diagnosis and treatment complex. Pain is predominantly due to nociceptive and inflammatory stimulation, which diminishes over a predictable time interval. Typically, it is at 6 to 8 weeks. By contrast, chronic neuropathic pain is due to abnormal neural activity and can persist without ongoing inflammation goes away. So, CPIP often ameliorate with time. The characteristics should be remembered when considering invasive treatment for CPIP like ablation or neurolectomy. Laparoscopic review have identified some risk factors relating to growing hernia surgery. Relatively, young female with high preoperative pain is more likely to have CPIP. Also, pessimistic characters, recurrent case, and genetic predisposition are pointed out to be related to the pain. And also, palliatively, as everyone may know, less experienced surgeons and using a heavy mesh handy, and post-operative complications and poor post-operative pain control induces also a risk for CPIP. So here is the inguinal anatomy. So the cutaneous nerves of the lower abdomen and the groin that are most frequently implicated in the etiology of persistent groin pain includes the ilioinguinal, ilioepigastric, and the genital femoral and lateral femoral cutaneous nerves. So here, very small. We really say nerve identification and management is key to protecting the nerves. Ilioinguinal, ilioepigastric, and genitofemoral nerves are mainly related to CPIP, so I enhanced the 3 colors, And sometimes lateral femoral cutaneous nerves also causes pain. Ilioinguinal, ilioepigastric, and lateral femoral cutaneous nerves runs frontal of lumbar great muscle. On the other hand, genitofemoral nerve runs frontal of greater psoas muscle. Ilioinguinal and ilioepigastric nerve emerges lateral to the internal inguinal link and exits from the external iliac link. And the genitofemoral nerve launches into genital and femoral. See, femoral and genital branch. And genital branch of the genitofemoral nerve exits the lateral peritoneum majorly at the internal inguinal link to run through the inguinal canal on the anterior surface of the spermatic cord. So here's a picture of the dermatome. Let's start with earlier. Here is especially related to the surgery of hernia repair. Ilioinguinal controls the sensory nerve around scrotum, labial majora, and the proximal and medial side, the orange area. And the iliohypogastric nerve controls on the skin of lower abdominal area and the groin. And the genital branch of genitofemoral nerve controls the sense of groin and labia. And you see this picture shows the textbook type model. But in reality, there is so much nervation and there is so much variation of nerves. So in case of neurolectomy for CPIP, operative mapping is mandatory to identify which nerves are the causes. And here is the laparoscopic view model. This is a very basic principle when you intend to start laparoscopic hernia surgery. So everyone may already know. Triangle of doom, the red area, is a triangle bound by the vas deferens, testicular vessels, and the peritoneal fold. This triangle contains external iliac artery and vein, and deep circumflex iliac vein, genital branch of genitofemoral nerve and femoral nerve. So you never step over suture here. And the orange area is a triangle pain. In addition to a triangle of doom and pain, nerves can be injured by deep tucking or suture in the area of C and D. So there's another slide. There's a magnified area of the same region. A triangle pain. Can you see the red area? Yeah. is a triangle bound by the aeropubic tract, testicular base cells, and the peritoneal fold. Do not cut or staple the mesh below the aeropubic tract. Here. Because both of their dangerous area are below this line to minimize the chance of damaging nerves and vascular structures. So all hernia surgeons consider surgical staples above the aeropubic tract line. And sometimes nerve can be found 1 or 2 centimeters above the aeropubic tract. So 2 centimeter cranial to suturing would be ideal. So already Dr. Manish explained this inverted Y and 5 triangle. So danger zones are both below the aeropubic tract, you see. So I'll show you the Japanese approach of laparoscopic hernia surgery. In many countries, their standard techniques start from a high incision of peritoneum, typically ranging from a few centimeters cranial to the internal inguinal length. But in Japan, you see, a common practice is to initiate the peritoneal incision from the lateral and the lower region and perform a circumferential incision to dissect the hernia sac. See? So this is making a circumferential incision first. The key distinction lies in the location of the peritoneal incision. Internationally, the incision is made cranially, where the membrane is often used, requiring the surgeon to delve deep initially and then return to a shallower layer. But the Japanese technique starts the incision from a less adhered lateral and lower layer, forming a circumferential incision that allows the surgeon to remain in a shallower layer, we think. So this circumferential incision approach are notable advantage, especially for beginners, as it minimizes the need to change layers. According to a nationwide survey in Japan regarding post-operative pain after hernia surgery, only 0.5 of individuals reported significant pain at the 3 months post-operative mark. So this is a top video, but the basic concept is same with the tab. And here's the diagnosis and the treatment process. So this is very congested, right? So post-operative pain following glowing hernia surgery is common and easily treated with acetaminophen or non-steroidal anti-inflammatory drugs. Most often, post-operative growing pain subsides within 6 to 8 weeks, but pain persists more than 6 months. Post-hernial neuralgia can be diagnosed. We suggest that pain in such patients be managed with multimodal analgesia, including a nerve block. Imaging studies, such as ultrasound, computed tomography, or MRI, should be considered to identify non-neuropathic sources of pain like mesh infection or recurrent hernia that may not be apparent. Some people prefer MRI because it is more sensitive and less operator dependent, but I believe it depends on the situation. So for patients diagnosed with CPIP, a growing nerve block should be performed to control pain and confirm diagnosis. Although a positive response to peripheral nerve block supports the CPIP, a negative response does not exclude the CPIP because mesh-related fibrosis and inflammation impairs the spread of anesthetic drug. If a specific glowing nerve block is reproducibly effective but is transient, that nerve can be sacrificed to achieve permanent pain relief. A nerve sacrifice can be accomplished by percutaneous nerve ablation or surgical neurolectomy. Nerve ablation is performed in a similar manner to nerve block, except that a neurolytic solution like alcohol or phenol is injected. Alcohol or phenol injection permanently destroys offending nerve ending and reduces chronic inflammation caused by the mesh or post-operative fibrosis. Alternative techniques of percutaneous nerve regulation such as radiofrequency or cryoablation, have also been described. The main is the phenol and alcohol. Neurolectomy relieves growing pain in the majority of patients with neuralgia and is indicated when all other measures to pain control have failed. Neurolectomy involves identification, dissection, and resection of, ideally, the entire length of a nerve, leaving smooth muscle to be ligated or buried with the muscle. The often laparoscopic and the combined approach have been described, but there are no trials comparing these approaches. A triple neurolectomy involves resection of the ilioinguinal, iliohypogastric, and the genital branch of genitofemoral nerve. Triple neurolectomy relieves chronic pain permanently, and some papers say that over 90% of patients are effective, but we have to remember that there has more collateral damage like complete loss of sensation and the bulging of lower abdominal area. And the selective neurolectomy removes one or more nerves depending upon intraoperative findings or preoperative mapping. Also, selective neurolectomy avoids the chronic sensory deficit of triple neurolectomy. It may not be as effective as triple neurolectomy in relieving chronic pain. So, according to our papers, 6 to 70% are effective. And the fail performing surgery for post-hernial neuralgia, many typically remove old mesh and replace it with a new one. So, as you see, the CPIP treatment and diagnosis is totally complex, so prevention is the most important. And when you try to hernia repair, always think about nerves. And we believe that lateral and lower first approach may be safer, especially for beginners. Thank you for listening.
This is very important topic. This is distressing. This problem is distressing to the patient, not only to the patient, but also to the surgeon who instead performs the procedure. So this is quite interesting, and he presented quite elaborately. Thank you very much for the presentation.
Okay, now we'll move on to next topic, the strategy for recurrent inguinal hernias. I would like to request Professor David Lomanto to deliver his talk.
All the local people for the organize such events. I think we are celebrating 11 years of ELSA outreach program activity in Nepal. This is actually it's eight times. Thank you so much. And as you see, it's ELSA OP organized board. This is a 102 workshop. So a lot of effort in the last 10 years. Thanks to all the people who join us, Randeep, Manish. This time we have two young guys from Nepal, I don't know, Japan, Sansim and Junpei. So thank you so much, and Ashwin also to join us. So I have a series of lectures. The first one will be on recurrence, how to manage recurrence. How to manage recurrence, I think this was my slide yesterday, even though we have a bit of trouble, but we have a chance to see the famous Nepal mountain, except my preferred Annapurna. That will come later. It was a beautiful view from the plane. When we talk about recurrence, as we are surgeons, we always say we don't have complication, we don't have recurrence, we don't have anything. Also, Titanic never. They say when they launch the ship, they say this ship will never sink. And unfortunately, when we look at the recurrence rate, if we look at how many patients you operate for recurrence, you will have the number of recurrence, the real recurrence. Because people say recurrence is 1%, but in my series is 11%. 1989 is a primary hernia. There is a recurrence. Or everybody is wrong, or everybody is right. We don't know yet. But if we look at the study population, we don't look at the academic center where we do thousands of hernia, like Manish and Deep. So the recurrence is low. But if we look at study population overall, we see that the recurrence vary between 8 to 15%. It doesn't matter open or lap. The recurrence is always the same. Depends on the skin. So the recurrence range, but we need to look at the wide picture. Today, especially in a specialized center, the recurrence is below 2%. And it's changing across the world and worldwide, because today we have more laparoscopic cases, more open, less suture repair, more mesh. So the trend and the number that we have till now are data that are 10 years ago. So they don't reflect the reality. That's very important. And you see that the number of proportion of recurrent hernia also going down, because we become better, we have more workshops like this, we can share more knowledge, more tips and tricks, so we can improve our skill ourselves too. When the hernia recurrence, the hernia usually if recur within 3 months is a technical error. We cannot blame the mesh, the patient, anything. So we should look at ourselves and try to improve, because we have done something wrong. When the hernia recur after 1 year, maybe due to other factors, patient factor, mesh-related factor, overreaction of the body, metabolic disease. Don't forget the hernia is a collagen defect. So if you repair an indirect hernia is one problem. If you repair direct hernia is another disease. There are two different diseases. So you must understand more also about the physiopathology of the hernia itself to understand a better repair. So if you look at data from US, 25% of the hernia recurred within the first year, 25% after within 1 year to 5 years, and 50% after more than 5 years. So the trend of recurrence is life of the patient. You cannot say if you don't recur after 1 year, may not recur. What are the mechanisms? The mechanisms are different if you do open or if you do lap. If you do open, mostly because the mesh is small, we should remember that we always need to use 10 by 15 mesh. We don't need to trim until it becomes 4 by 5. Mesh must be wrinkled. It's there. It will shrink 30%. Every mesh will shrink in 10 years 30%. So if you put 10 by 15, in 10 years time will be 30% smaller. So if you put 6 by 9, in 10 years time will be 2 centimeters. Patient will have a recurrence. So you just look at this. You can always say, okay, in 10 years time it's not my problem. Right? I did my job. Many surgeons, they say, okay, I do my job, in 1 year time, patient recurrence is not my issue. So most of the time for open is the medial recurrence. The overlap that Liechtenstein described in his paper of 2 centimeters of the pubic tubercle is not always maintained. And of course, if you have direct, most of the time it's because of the weakness of the fascia transversalis and so on. And if we do a plication, we also increase the risk and recurrence because the tissue will tear. So in terms of classification, we always use the same European classification. There are some other classification going on, you know, the Gilbert and Nius and so on. But usually we talk about R1, R2, R3 according to 1 finger, 2 finger, or 3 fingers size of the recurrent defect. So when we repair the hernia, of course, the recurrent hernia is more difficult because the anatomy is distorted, because we don't know what's happened, what surgeon did before, if additional stitches and so on. But they usually, when we have an anterior repair, the best way to repair is posteriorly and vice versa. So what are the risk factors? There are some patient-related risk factors, like smoking, we all know, obesity, diabetes, Marfan collagen disease, and so on. And of course, there are surgeon-related that we should concentrate more. Maybe wrong indication, wrong approach, very little experience, maybe mesh not appropriate. When the hernia recur, usually when we have guidelines that allow us to do a proper repair, and this is the standard today. But today with more posterior repair, and sometimes more recurrence after both anterior and posterior repair, there is no guideline that tell us what to do. What is the best repair? So laparoscopic gaining approach, more popularity. So we are going to have more recurrent after posterior repair that are the most difficult to repair today. But we have sometimes also anterior, posterior, very little experience, patient re-recur. So we need to prepare for a trend of more difficult recurrent and hernia in the future. So we have patients that underwent prostatectomy. Robotic prostatectomy is quite common today, laparoscopic prostatectomy, so posterior repairs become more difficult. And usually we have noticed that patients after prostatectomy, they have high incidence of hernia. So we are going to have a pelvic that more distorted anatomy and more adhesion. So we need to understand the cause of repair. So what is the best way, in my opinion, when you have a recurrent hernia, do a diagnostic lab. I am a top TAPP man, then I moved to TP, 90% of my practice is TP. But when I do recurrent, and I used to do recurrent with the TP approach, but now I do mostly TAPP approach. Why? Because I like to understand why the hernia recur, where the hernia recur, where is the mistake, and tailor the repair to the recurrence rate. You can see we analyze some data. We are an academic place, so we always do study and so on. So we have seen a lot of recurrence and re-recurrence, and that we are going to talk about that. So when we see re-recurrent hernia, we can see that most of the time the content is omentum, small, sometimes small bowel. There is always a mesh there. There is always adhesion, and in terms of morbidity, you will, of course, is higher. Patients have a little bit more chronic pain after, and even transitory pain after the repair, may have more seroma because it's a scar tissue and so on. So, what are the causes of recurrence? What we learn? You can see in some of the video, the mesh sometimes is too high, or the mesh, patient overreacted to the mesh shrinking. So there is more, the mesh is a synthetic mesh, it will not shrink. It's the scar tissue around the mesh that will tighten and shrink the mesh. So most of the time we notice that is a mesh positioning, or the surgeon scared to dissect on the inferior part. On the inferior edge, so we must remember that we need to enter the retroperitoneum. Okay? When we do hernia, it's a preperitoneal approach, but we need to push down the peritoneal reflection until we are able to see the psoas muscle that is a retroperitoneal in the retroperitoneal position. So the mesh, our dissection must be lowered down until we enter the retroperitoneal space. In a thin patient, you can also see the iliac quite well, but that's very important. So we need to go, imagine, just a little bit behind the right column. So that's why most of the time the mesh is high, and also the overlapping on the midline is missing. So these are the most common cause of recurrence. I have quite a number of cases. So what is our approach today? So usually when we have a previous mesh repair anterior, of course the options are vary. Laparoscopic, always a posterior approach. If the hernia is a massive, is very big, we go for an open stoppa repair because we want to have a big overlap. So we want to have maybe a 15 by 20 mesh to avoid another recurrence. So if there is a previous posterior repair, you have two choices. You go anterior. If you have multiple repair, we always do laparoscopic because it's the best way, the posterior repair to handle it. So you can see cases like this in which patient already have a recurrent sliding hernia because of anterior repair. So you can tailor the approach. When the patient are a little bit chubby or obese, actually it's much easier to do. We always look at the anatomy and we try to remember what is behind the adhesion. Even there is an anterior repair, the mesh can be translated in the posterior plane. So remember always that you have a vas deferens. Don't try to remove the mesh, go behind the mesh if possible, or go across the mesh and reduce it. For matter of time, we speed up a bit. We have a few cases. For example, this is another patient. He got a TAPP, he got a Liechtenstein, he got a TEP. So what to do? So in this case, patient a little bit obese. So we always do a posterior repair. A posterior repair, and we go across the mesh. I suggest always to start on the side that there are no mesh and no adhesion. You can see most of the cases that recur are direct hernia. That's why today we do a TEP plus. We always close the direct defect with a suture. And in case of large inguinal scrotal, we also reduce the size of the external ring. So in this case, you have different options. You can use the sac, the hernia sac, and do a peritoneoplasty using the sac. You can use a TAP approach, so partially use a mesh like a ventral hernia, so the mesh is partially exposed if you cannot cover with the peritoneal flap because of the adhesion. So you have different options for cover up and repair. But important that you do a repair that is will not lead to another recurrence. So fixation to the pubis bone is very important, and also in case you use you don't have much overlapping, also suturing the mesh on the bottom side will help you to avoid any sliding hernia below. You can see we use a V-lock suture to close the hernia direct to avoid that the mesh will go inside the defect. There is no nerve there, we all know. I think the beautiful lecture on anatomy by Manish, we tell you that over there, the fascia transversalis, there is no nerves. And actually, when you do anterior, most of the people do displication of the transversalis. So closing the direct defect is a must today to reduce the recurrence rate. In this case, we do a TAP approach, in which superiorly we can fix, and inferiorly you can you can do the suturing. We have other case, so you can consider different options. So the classical IPOM still valid in selected case, TEP approach, or if you are lucky and the mesh is very, very high, you have enough overlapping to cover up in the TAP standard fashion. So what are the tricks for managing a recurrent hernia? So try to get as much information as you can about the previous repair. Of course, if you have done 20 cases, 50 cases, maybe just call for help or ask for somebody with the expertise to help you. get a great camera, a good assistant. Try to do a repair that is permanent, will lead to less recurrence. Catheterize the patient because the surgery may be longer, but also if the middle recurrence, the bladder may be there and may be adherent to the mesh. So adequate extent of consent for orchidectomy because injury may happen. And in terms of technique, you need to be able to do everything. TEP, TAPP, IPOM. There is no way today, or this silly debate, I do TEP, TAPP is the best. If you want to be an hernia surgeon, you need to do both. There is no one, because you adapt your technique according to the patient. So you must be able to do TAPP, TEP, and everything. So keep in mind the landmark. Every time you do, you stop and say, okay, what can be the vas deferens? Where can be the vessel? Epigastric vessel, you can ligate. But if you ligate, when you go down, they are still there. Remember, epigastric vessel is an anastomosis between internal iliac hypogastric and superior mammalian. So the blood comes from both sides. So not because you ligate, you go down and you will not bleed. We bleed again. So stay above the mesh. If you can avoid to cut the mesh, will be great because it's a supporting for the repair. Start from the place where there is no mesh, where the virgin area, and then you move towards the mesh side. Tackle the hernia at last, so create all the space and everything, and then you tackle. And don't try to remove the mesh because it's a mission impossible. And fix the mesh even with titanium clip or stapler because you want to have very, very low recurrence. For multiple recurrence, consider the old-fashioned IPOM with the reinforcement on the bottom side. Thank you so much. We invite you in October for the World Congress in Singapore.
It's a very difficult job, a very difficult situation to tackle. The recurrent hernias, whether it's anterior or posterior, very crisp and nice tips. So I'd like to ask Professor David Lobanto to continue with his second topic, management of complication in laparoscopic groin hernia repair.
Recurrence. It also says that. And we also faced issues like that.
Okay.
We experienced
There are, okay, there was a, there are, the definition of lightweight mesh is not correct. Because there was 6-7 years ago, there is mesh that are 15 milligram per square meter, 30, 65, 120. 120 they consider the heavyweight mesh. But today there is no more. So all the mesh are medium weight. So you don't find those 15 milligram, that 15 milligram per square meter. The one you are probably referred, they go inside. The only way to reduce recurrence in direct area is to close the defect. You can put any mesh. I can show you a picture like I did last week, heavyweight mesh. The mesh was flipping inside because there is no fixation on the bottom side. So if you have an M3 direct hernia, the risk of recurrence is 20%. So the mesh doesn't influence much the recurrence rate. But if you have a large M3 defect, you can put any mesh you want, it will go inside. The only way to reduce is to use a larger mesh. Then you do a GP, like a stopper, you use a 15 by 20 mesh, then it's fine. But if you use a classical 10 by 15 mesh, there's no way to overlap enough below the pubis bone, more than 1 centimeter. So let's say one of the issue.
Thank you.
Okay, we are here. You have patient today with the warfarin, Plavix, aspirin, so all things that lead to more complications. Then we are talking about an anatomy that is not really familiar, even though today is after 20 years of laparoscopic hernia. I think almost all of us have experience with the challenge of the posterior approach. Especially when you do a left hernia, you never notice laparoscopic, but you are going to use your non-dominant end. It's not very ergonomic compared to the right side. So there are difficulty also in the size of the hernia. Of course, recurrent, as I say, because today we are more recurrent, indirect, and so on. So the complication also reflect our learning curve. When I teach my residents, I say, don't worry, you have 20 cases, you will come back to me with 3 or 4 recurrents. No need to worry, just continue to do your job. We will fix the problem. And in fact, they happen most of the time during the first 50 cases. So that's why the only way to reduce your recurrence when you start hernia is to select your patient. Choose small indirect hernia, small direct hernia, female patient. There are not many, but today more. So start to learn with simple patient, and maybe ask for help for more complex patient before you embark in a large inguinal scrotal and so on. So, then more complications. There are complications that may happen during the surgery or after the surgery. During the surgery, what are the most common? Vascular injury of the epigastric vessel and injury of the corona mortis, the plexus line on top of the pubis bone. Why? Because sometimes we excess of dissection. Very little are the injury of the bowel, even though are reported even after TEP, more after TAPP. Injury of the bladder happen, especially for large direct hernia. Nerve injury is quite low compared to open, because usually we don't go beyond the lumbar fascia, actually we shouldn't go. And injury of the cord structure also may happen in the low case. Unmute. I need to unmute? No, it's unmute. So the most common, especially when you do TAPP, the trocar position, lateral trocar position may affect your injury. Of course, varus needle also, when you enter, sometimes you use a palmar coil because the patient is a bit chubby, so you may have injury of the spleen. And of course, epigastric vessel, because remember the path are the one you can injury during the insertion of the trocar for TAPP, and during the last section, when you move towards the lateral space, when you go to the lateral space of Bogus during TEP. Those are the most common injury. Together with the vessel over the pubis bone. Another issue that we have when we are not familiar is the peritoneal tear. Remember all the peritoneal tear, I don't know why the video doesn't work. Anyway, the peritoneal tear that you must close. You can use an endoloop. If it's very large, you can use a suturing. Today with the V-lock suturing, it's very easy to handle. No, here, the video was here. Okay. And this is a very common injury of the inferior epigastric vessel. Like in this case, I always say, don't panic, just get a grasper, compress, big grasper, large grasper, compress, then you can clip. Don't rush to control the bleeding if you don't have the right instrument with you. Also during TAPP, it may happen. Sorry. During TAPP, it may happen. For the corona mortis, you must understand that that vessel around the bone is very difficult to clip. So, if you dissect and scratch the bone, you may end up with this bleeding, very difficult to handle. What to do? just compress. Put a gauze, tonsil gauze inside, compress, and try to change the setting of your dietary machine in a spray mode. You change on a spray mode, and then you can control, because it's very difficult to put any clip on the vessel that is flashed up on the pubis bone. So get a tonsil gauze, compress. You can use a spray mode, a 40, 50, depends on the setting, and usually you're able to control. Visual injury occurs in about 0.2%. It may happen during working or during trocar entry, during the dissection, and especially when you enlarge inguinal sliding hernia, or you may have delayed enterotomy because of the use of diathermy. Let's see some intraoperative complication. I think this is from Rajesh. Not Rajesh. From Rajesh. Okay, injury, so we can bypass, but it's quite interesting, this injury. I think everybody will laugh. I have a great collection of complications that because we usually always run a disaster in hernia, both in one. So this is, you can see, I always say never pull the bowel, especially when you have adhesion. Use your scissors, because if the mesh is behind there, it's going to be partially eroded inside the serosa. So if you pull, you are going to create an enterotomy. Maybe you should also stop instead to continue to pull, but the surgeon is very stubborn. You can do a cystoscopy since you are there. So close the enterotomy, put a catheter, and 2 weeks patient will be fine. Injury of the core structure. It may happen when you have really less experience because you pull. In this case, the surgeon misunderstand the residual sac, the vas deferens. He was thinking there was a residual sac. He tried to do a there are other methods to reduce the natality than cutting the vas deferens. So, what to do? Anyway, I went in, I just put the 4 suture, Prolin 5-0. We don't know. Still they have a contralateral side. Unfortunately. I use the same system to do a revascularization. Peritoneal close, I show you the case before, so we always, with a patient, that also happened to us with the IO post-op, so we need to go in and reduce the problem. Sorry. So there are different ways to close the defect. As I say, you have an endo loop. If the defect is very large, because the hernia was a huge immunosclerotal, you are not able to do transaction, the best way to do to use a vicryl and absorbable suture intracorporeal, and then you do. That's what give you more. So you just close the flap. Another option is to go in the TAPP fashion and you close from inside. Depends how you are comfortable. You can use hemolock for small defect. What about nerve injury? Never go beyond the lumbar fascia. Right? You remember a bit the anatomy, laparoscopic anatomy, the arcuate line, from the arcuate line, the fascia transversale start superficial and deep. Laterally go to the lumbar fascia, medially go to the cremasteric. Okay? So important that you don't dissect more until you see the transversus abdominis. So when you see blood, I always say you are in the wrong plane. So injuring this vessel is quite difficult. And today we almost use absorbable tacker too. I know that used in India still use capsule, right? Some metallic, but usually we don't use it more. So what is the fixation? Only 2-step absorbatak or sorbafix or any absorbatak on the pubis, on the Cooper, one medial to the epigastric vessel and one lateral. That's all. You don't need to put more than 4 or 5 clips, right? Because the mesh, if you have a good position, will be okay. You don't need to do like this surgery. Look how many steps? 35. So patient cannot walk. So need to be also careful. We go back to recurrence. We already talked about recurrence before. So recurrence happened. So there is no way to prevent, just improve your technique and adapt your technique to the patient. So reduce the femoral hernia. Remember to reduce the recurrence. Check all your myopectineal orifice, okay? And avoid to lift any hernia behind, even though it's a simple preperitoneal fat, because pain can be there. Same for obturators. So try to reduce all the hernia and clear all the myopectineal orifice properly. Yeah? Mesh infection is the most difficult situation that you need to handle. Luckily, for at least for laparoscopic, it's much less than open. But when happen in laparoscopic surgery is a dramatic situation. There is no way to treat an infected mesh except to remove it. You can keep for 6 months antibiotics. There is no way to cure it because it's a foreign body. Once you get infected, you need to remove it. So usually, the best way is to go posteriorly. The mesh usually is floating within the pus, so it's very simple to reduce. Don't try to put any biological mesh, anything, just leave it after 1 year. If the patient has no more infection, you can do an anterior repair or something else. But try to remove all the mesh en bloc. And possibly using a plastic bag. Then you can just close and put a drain outside. Okay, thank you so much for the complication.
And so, may I call once again Dr. Manish for his second talk. He'll be talking about decision makings and some guidelines of the groin hernias.
छैन भनेको लिन तैँले
कसले भने छैन त्यसबाट पिङबाट आउँछ क्या ठुलो मान्छेको जति पुग्ने हुन्छ क्या त्यहाँबाट ठुलोमा आउँछ सानो साइज त्यहाँ टक्नु फ्लाइट पनि त्यहाँ आउँछ
पुग्दैन त्यहाँबाट कुनै ठिक छ बरु
पर्दा लगाउनु लाग्छ
there are so many guidelines emerging regarding the hernias in these guidelines to make our life easy.
So, respected Chairman, them have already been shared by Dr. David, and this is about what the guidelines say, what we should do in these situations. And these are 5 scenarios that I'm going to share in the next 15 minutes. So thank you very much yet again, and I start with my, it's not moving.
Click on the video.
Now this has happened during the COVID days. She comes with acute intestinal obstruction. She gets worked up and diagnosed to have an obstructed femoral hernia on the left side. Now, a 91-year-old lady, acute obstruction, what options do we have? So should we approach it through an open method, just under local anesthesia, open under GA, or do a diagnostic lab and proceed? So this is a big dilemma. This actually depends as to what your expertise is, what is the expertise of your anesthetist, what is the kind of backup that you have. So we prefer to go in through a diagnostic lab approach. And the reason behind I will discuss after this, after that you've seen the video. Now this video will also show you how to prevent injury to the bowel when you have a tight obstruction with a knuckle of bowel going in. If you try and pull it out, you are going to injure the bowel. So you have to go all around the ring which is obstructing and try a little traction from inside. Just try and maintain that traction. Do not pull hard. You are able to do that, enlarge the ring. So that's another thing that you will do. And moment you do that little enlargement of the ring, with a constant delicate traction, you are able to get this out. Now this is a 91-year-old lady. We've got the bowel out, which is doubtful. So we do all the things that you're supposed to do to check on the vascularity. Today you also have ICG. In case you are not sure, you can also use ICG if you have the equipment, and be sure about the vascularity. Now the big question was whether we should use a mesh or we should not use a mesh. But with a 91-year-old lady, we said she will never give us a second chance if she has trouble. Just putting sutures to that ring is not good enough. So we did the TAPP approach, we placed a mesh. In the end, we looked at the bowel looked well, and patient actually went back home in 48 hours time. This is 91-year-old lady. Now this is probably, we were lucky, she was lucky, came in at the right time. Things happened well for her, and then it's actually a standard TAPP. I'm not going to show you the entire procedure. And patient did well. So what is the message, what we have learned from this? What do the guidelines say? It is extremely, extremely clear. If you have a lady with a groin hernia, what is the procedure of choice? Procedure of choice is always a laparoscopic repair because of the high incidence of femoral hernias. So even if you are not competent enough to do these repairs early part in your career, you must do a diagnostic laparoscopy or ask for help. Femoral hernia, we all know, repaired through an anterior approach is not very good. There are very high chances of recurrence. So a femoral hernia is best repaired through a posterior approach. Do a diagnostic laparoscopy in patients, in all women with inguinal hernias. So that was learning number 1, and this is what the guidelines tell us. Women with inguinal hernia, posterior approach is always superior. Now this is something we encounter every other day. Patient, 45-year-old male, incarcerated, right inguinal hernia, cholelithiasis with chronic cholecystitis. Now what happens first? Or do we do them together? So should we do a combined procedure? We do an inguinal hernia and a cholecystectomy together. Should we do a laparoscopic cholecystectomy followed by inguinal hernia repair? or you do a TEP, TAPP followed by a laparoscopic cholecystectomy. So if I speak to n number of people separately out here, a lot of them would say, okay, if the hernia is incarcerated, just omentum, let's do the gallbladder and do the hernia later, and some would say the other way. What we have seen is these patients, usually they'll come to all of us and say, I want a combined procedure. Now, whenever you're taking a consent for a combined procedure, you will also take a consent that the decision will happen only on table. Even if the patient has come for an inguinal hernia, you are attempting a combined procedure until unless it's an obstructed inguinal hernia, then of course inguinal hernia takes priority. Otherwise you'll do a cholecystectomy first. Why? Because if there is any potential spillage, pus lying in the gallbladder, you will defer the repair of inguinal hernia. But if you land up doing the inguinal hernia first and then you go to the gallbladder and see it's an infected gallbladder, then you're in trouble. So always approach the gallbladder first in case of combined procedures, and then do the inguinal hernia if you are 100% sure. So what do guidelines say? Hernia repair involves use of a prosthetic mesh in majority of situations today. So hernia repair should always stay as a clean surgery, not even clean contaminated surgery. Now there is a lot of literature available today wherein we are doing bariatric procedures with ventral hernia procedures or inguinal hernia procedures, but these are not huge reports. You have to see how much risk-taking appetite that you have. Given a choice, when we counsel our patients, we always prefer to do hernia surgery as a hernia surgery, not combined with any other procedure. Or if you are doing any other procedure, defer hernia for a later date. Cholecystectomy should be done before hernia repair for the reasons that I've already discussed. Inguinal hernia needs priority. If incarcerated content is bowel, then of course that needs to be addressed first. The rest, everything follows. Now, these are difficult situations. This is something you've just seen David present similar thing. This is a 58-year-old male. Bilateral inguinal hernia, lower abdominal laparotomy scar looking like this. So what do the guidelines say? I will come to that a little later. So patient is taken up for a TAPP repair. These are the options. TAP repair, TAPP repair, open repair. TAP repair is almost out, avoidable, because those planes are already been handled. So when you do a TAP repair, beginning of your surgery, you will make multiple peritoneal holes. So do not do it. So the choice is between TAPP and open. TAPP, if you're experienced enough, you can do it. But even in experienced hands, this is what happens when you go in the midline and you will have a dense adhesions in the midline. Unable to see the planes well, you land up with injuries, and this is a similar thing that you have just seen. So you see an injury there. Surgeon has still not seen it well, and now he sees it, and that's a bladder injury. Now when you land up with a bladder injury like this, now what do you do? Will you suture it? You will continue with TAPP repair. You will convert to an anterior tissue repair, convert to an anterior mesh repair. Of course, prevention is the most important thing. So what do guidelines say? If the patient has had good preoperative workup and you are sure that the urine was sterile, you can actually go ahead, suture, put in a macroporous mesh, and you can get away in the situation. But slightest of doubt, you will put sutures there, you will leave a drain there, and you will come out. This patient had a repair of the bladder, placement of the mesh, but this is always a possibility. Now, the big question is, how do you prevent this? One reason is you don't do a TAPP at all, you go ahead with an open repair. Now, this is what we've started to do after we have seen couple of injuries like this. Number one, always use a good device. Use a harmonic, use an end-seal. Don't use a monopolar diathermy because it will give you a messy field. Okay? So that's one. Number two, when you get to the midline where you are having trouble, you are anyways going to put in a Foley's catheter in these patients. So what we do is we distend the bladder with the Foley's catheter. And once you distend the bladder with Foley's catheter, how clearly you see the margins. And once you can see the margins well, you are sure you are not going to injure the bladder. So let me forward this a little for you. So that's the midline. That's the bladder. You can see the bladder getting distended there. So once we've done that, we are sure of where the margins of the, and now you can clearly see between the pubic bone and the retropubic space. That's where the bladder is. So in cases of this difficulty, this is another tip that can be used. So what is the message and what do the guidelines say in presence of scars? In patients with pelvic pathology or scarring due to radiation or pelvic surgery or those on peritoneal dialysis, consider an anterior approach. So these are recommendations. Consider an anterior approach. If you have a good amount of experience with laparoscopic repairs, TAPP is an option only once you have good amount of experience available. So in a situation like this, this is what the guideline says. Another difficult situation that you've just seen. A patient who's had a TAPP 3 months ago comes with a sinus anterior abdominal wall of 2-week duration. Scars look normal, counts are borderline. This is how it looks. It's a small little sinus which is continuously discharging pus. How do you handle this? In our part of the world, whenever you have a sinus like this, before you can actually make a diagnosis of mesh infection, there is another important thing that you need to rule out is infection of ports with atypical mycobacteria. This is something which is not there in literature much because it's not there in Europe, it's not there in America, but we see in our part of the world. So you need to rule out, you just take a scraping or just take some amount of pus, send it to your microbiologist, ask them to look for atypical mycobacteria. If it is atypical mycobacterial infection is infection of skin and subcutaneous tissues. So this is the only place where you can actually salvage the mesh. If it is negative, you do an ultrasound, you do a CT, there is large amount of pus lying on both sides of the mesh, then there is no other way to treat this but to get the mesh out. So mesh salvage only possible if it is not a mesh infection. Mesh infection, it needs to come out. The problem is the presentation is always delayed. Your mesh is in the deeper layers. By the time it presents, it's late. So explantation of the mesh. So when we started explanting early in our experience, we used to do it through the anterior approach. But now this is what the guidelines also say, that posterior mesh, remove it through the posterior approach. And the reason why we say remove it from the posterior approach is not because the mesh lies posteriorly. Ease of removal, morbidity is less, and in the end these patients are going to need another repair. So if you remove the mesh anteriorly, you've spoiled the posterior planes and the anterior planes. You won't be able to do a good anterior repair. But if you've removed it posteriorly, you will still be able to do the anterior repair. So get the meshes out, make sure all the fixations are out. You have better vision on laparoscopy, you can see the entire cavity. Always place a mesh and always close the peritoneum. Or always place a drain. So the drain should always come out at the edge of the peritoneal incision. But you have to close the peritoneum. Otherwise you'll have a bowel loop going inside and patient coming in to obstruction. So this is about mesh infection. So guidelines, prevention of mesh infection cannot be overemphasized. Now we were just talking about combined procedures. 99% of the times when the patients come to us for a combined procedure, we actually refuse. And when you convince them well, they agree with you. So avoid doing combined procedures. In case of infection, early mesh explantation should be done, and laparoscopic explantation causes less morbidity. Coming to the last one. Now, this is another thing what we have learned, and there is enough data which is coming. What happens to the recurrence when it happens after a TEP or a TAPP repair? So guidelines would say do a anterior repair. But is it always justified? We have just seen Dr. David show us video in which the size of the mesh was very little. Okay, so this is what the guideline is by hernia, surge, IEHS, everyone says the same. So is there a place for re-laparoscopic repair? Now this is a brilliant article from Kokeling and Group, and this comes from the German registry. The only registry which actually looked at recurrences after posterior repairs, re-recurrences. And what did they conclude? An inadequate previous posterior repair would still warrant a good TAPP repair in expert hands. And when you see these multiple pictures, now this is a patient with a bilateral hernia with a recurrence on the right side. You see there is no mesh medially. Most of the mesh has migrated laterally. So either a small size of the mesh, wrongly placed mesh. Now look at this, a lateral recurrence. You see good amount of mesh on top. There is no mesh there. So this usually happens during desufflation. Your mesh is not spread well, this place is not dissected well, and you will have the mesh roll up and you have a recurrence there. Similar, recurrence laterally, there is no mesh there. The mesh has actually moved up completely, upwards and medially. So you have a lateral recurrence. Now these are the patients who've actually not had a good primary posterior repair to begin with. So when you do a diagnostic laparoscopy, you actually get to understand why this recurrence happened. Now look at the size of the mesh. This patient has had a recurrence. So both sides, luckily to not have recurrence on the left side, but there's a recurrence on the right side, a small little mesh lying in there. So start from the area which appears relatively virgin, and you can actually do a good posterior repair in these patients. You have to be careful. Now this is not a recommendation, this is the feasibility of a procedure, something that you have to understand. But yes, we can give this benefit to our patients. You do a diagnostic lab, you see dense amount of adhesions in that area, marble is that area. There's no reason why you should continue with that TAPP repair. But if you see situations like this, now look at the direct hernia getting reduced, it's like a primary repair happening. Okay? So these are all inadequate repairs where we can give benefit to these patients. So, but after having looked at all this, this is something we always have to follow, and there is no way we can get away. That is primum non nocere. Hernia surgery is best what is best in your hands. So do something you're confident about, look at your infrastructure, see at what level of training you are in, and that's when you should offer these procedures to your patients. So thank you very much for your attention.
For questions, for the last topic, you know, ask Dr. Manish if you have any queries.
Question on the last part. I also agree with you. Like the posterior repair, it's always like the recurrence means it's inadequate. So and then you go on. There is a very, I think doing the laparoscopy and seeing if you can actually go do a posterior repair is a very good option. So my question is, what do you do with the mess that's already there? Like say, it has a very good coverage of lateral triangle, and then the mess is very nicely in the lateral lower half, in the danger zone. But it's a medial hernia, like the direct hernia is there, the medial plane is completely virgin and everything like that with dissection. So you will go on and dissect all the lateral plane, or just stay in the medial plane where the recurrence is?
No, so yes, we will do both the planes. Number one, you can never get the peritoneum away from the mesh and leave the mesh onto the anterior abdominal wall. No, that doesn't happen. Whenever you're creating a peritoneal flap, your mesh is coming down with the peritoneal flap. So take your harmonic or a good sealing device, take it down. At times what happens is, the challenge, if there is a lateral recurrence. So we have handled the lateral recurrence, and by the time we come to the midline, bladder is extremely densely adherent and you are not able to get it away. Then we'll just leave it there, because that bladder will not let a direct hernia happen in that place. So we will compromise on the size of the mesh, but the learning is your mesh will always come down as a flap. And believe me, majority of the times you can actually get it down well, because these are small meshes, rolled up meshes. Of course, if you're finding it difficult, you can just abandon and do anterior repair.
Is it worth endangering, especially for the lateral triangle, when there's a lot of nerves, like you are taking the mesh down means you are going deeper into the plane,
correct.
nearer to the plane. So I think that's the conflict.
Absolutely. So if there is a little bit of doubt, you will just abandon it there. But most times what we have seen is, even in these videos that you saw, rolling of the mesh usually happens lateral to medial, lateral to up. So lateral planes usually lie absolutely virgin. And this is how the recurrences are happening. So that issue usually doesn't arise, but if it arises, abandon it.
You have shown at the discharging sinus.
Yeah.
To me, it's most probably due to atypical mycobacterial infections. So what is the guidelines to treat this type of infections?
So
as it not available in literature.
So atypical mycobacteria as to how treated. So the chemotherapy for this is clarithromycin, amikacin, and one quinolone. It could be ciproflox, oflox. So what we follow is start with clarithromycin, amikacin for 2 weeks, and after 2 weeks, clarithromycin will continue for at least 1 week after all sinuses stop discharging. Usually the period is 3 to 6 months. So it's a long, prolonged treatment, and it works. So moment you have seen atypical mycobacteria, you can actually start with this drug regime. Works very well. They will look at atypical.
What is the percentage rate of detection in microbiology? Because in my experience, you may not get mycobacterial tuberculosis in examination as well. It's very difficult to diagnose it. To my experience, most important, a high degree of suspicion. The classic presentation is once the patient is discharged, after 3 weeks, discharging sinus appears. Not in the first week, not in the second week. If it's occurring in the 3rd week, then you must suspect, especially in our part of the world. It's not.
So that's is, if you have not seen atypical, you've started on chemotherapy, you will see new sinuses opening up. So that's when you don't have to discourage. This is how it works. You will see other port sites also discharging, and then eventually everything settles. There have been times when we have actually given this chemotherapy for 7 to 8 months, and single drug, clarithromycin, clarithromycin. So that's the treatment of choice. But very rightly said, not everyone will be able to pick up atypical mycobacteria. It is the clinical presentation. If it is a ventral hernia, if you think you've taken transfacial sutures, then of course you need to explore the sinus and make sure there is no suture lying there which has caused a sinus. But in TEP, it is just port sites which were discharging like this. Your first diagnosis is atypical.
Thank you, sir. I have a question for TAPP, like what is the lower limit for TAPP for peritonalization, and what do you do for the distal sac once you have ligated the sac, sir?
So I will answer. Teaching was you should try and get the entire sac out. So in doing that, your patients may experience a lot of testicular pain post-operatively. So we make a fair attempt to try and reduce the complete sac. If it is not a complete sac, if it's incomplete, it comes out. Otherwise, we will, the way you have seen, create a space between the sac and the cord structures, ligate proximally, and distally we just leave it open. So, and you should not close the distal sac, otherwise the patient will develop a hydrocele of the cord or a proper hydrocele, so you need to avoid that. Now, talking about the peritoneal incision, now that was very interesting to what I saw today. The Japanese have a different way of doing it. They start their peritoneal incision very low. We do the standard way of about 2 to 3 centimeters above and lateral to the deep ring, and you take the incision medially. Now, medial extent of incision was always taught in the typical TAPP was that you stop at a medial inguinal ligament. Now this we have learned from our robotic experience, it doesn't matter if you take it even further across the midline, you should be comfortably working. Earlier in your experience they said why you don't cross the medial inguinal ligament, the chances of bladder injury becomes higher. But once you are sure you're dissecting well, there's no reason why you should injure the urinary bladder. So you can take the incision there, and inferiorly it is similar to what you've seen in TEP. You should be able to peritonize the cord well. Laterally you're seeing the psoas, above you're seeing the anterior superior iliac spine. So that is the extent of dissection. And medial, of course, crossing the midline.
So another question, like end up with multiple holes in the peritoneum, how do you address those?
They need to be sutured.
Thank you.
So everyone has.
You can get your quality during the tea time. So to present the.
It is in the tea time. Because of the time lag, we are ending this with the presentation, with the certificate presentation.
Thank you, sir. I request Professor Bhojraj Nepane, sir, to do the honor to Professor Manish Bajal. Now I request Professor Kishore Manandhar, sir. Thank you, sir. I request Professor Pranil Rai and Sanjay Patil, sir.
Sir.
I request Professor Rakesh Kumar Gupta, sir. Thank you.
So I have few efficiency, and I have two important announcements to make, especially for delegates. Please go through clarinet, because you will not get each certificate if you don't attend through clarinet. Next is from special permission from David Lemanto, sir. We are organizing quiz competition tomorrow, especially for residents and students. And we have a special gift hamper, that is travel grant to upcoming ELSA, which is being held on Bali. So please be attentive, residents and students, please be attentive. There is attractive gift hamper for you.
Good morning and welcome back, ladies and gentlemen. I am Anisa Giri.
And I am Mausami Shrestha. We hope you have enjoyed your tea break.
Well, it is said that only the strong survives. To survive, you have to stand alone. It has been said from the very first day of standing, ventral hernia also stands with you. So without further ado, let's get started with the session 2, that is ventral hernia.
For that, we would like to invite our respected moderators for the session of ventral hernia to take their respective...
Please join me in welcoming our esteemed moderators. We are privileged to have Professor Mukunda Raj Joshi from KIST Medical College, Kathmandu.
Professor Romeo Kansagar from Green City Hospital, Kathmandu.
Dr. Sahil Rupakheti from Star Hospital, Kathmandu.
Dr. Rajesh Pauril from Universal College of Medical Sciences, Bhairava. Thank you for your time, sir. Now we hand over the floor to our moderators.
welcome to you all in this second session. Now for the presentation, for the first presentation, we would like to call Dr. Aswin Thangavelu for the hidden anatomy of extraperitoneal space.
Me the opportunity to be part of this wonderful program. So today I've been asked to talk on extraperitoneal spaces, and as you can understand, in the last few years there's been a lot of interest in the extraperitoneal space anatomy, and for surgeon I think anatomy is the key, and here we'll just try to touch upon the important aspects. So as you are all aware about the superior, inferior and lateral limits of what constitutes an abdomen, and when we look at the facial layers, it is important for us to understand about the superficial and the deep facial place and also the deep organ space. A little later in a different talk I'll tell you why it is important. And when we talk about the gross anatomy in a human being, so in the midline you have the linea alba, which is the central tendon, and the linea alba, it's a flat structure, it's not one single line, it's almost around 1.5 centimeters in a normal individual. And then on the lateral you have another 2 more lines which are very important, which is the linea semilunaris. Again, this is not a single line, it's a flat structure. Between these 2 lines we will have the retrorectus space. So if you look at the retrorectus space, it is actually not one single space. You have a right retrorectus space and a left retrorectus space, which is separated in between by the linea alba. A little later in the talk I'll tell you why all this is very important for us. And this is how the cross section of the anatomy looks like. So this is the rectus sheath which you see, and when you dissect it off you can see all the rectus abdominis muscle with the tendinous insertions, and laterally when you remove the external oblique muscle you can see the internal oblique. You can see how the fibers are complementing each other, and then you have the transversus abdominis fibers. And also the anatomy of the rectus sheath is a lot different above the arcuate line, where you have a anterior and a posterior rectus sheath enveloping the rectus muscle, whereas below the arcuate line if you look at it, it's only the anterior rectus sheath, you don't have a posterior rectus sheath. With regards to the anatomy, it is important how the zonal anatomy varies, because if you have an incision of say a laparoscopic or an open cholecystectomy scar in this zone 2, then the zone 3 blood vessels are already dissected off. So then we have to be wary on how we decide on the incision we make for subsequent hernia repairs. If you make another incision in the zone 1 area or zone 2, then there are 2 zones which are going to be cut off. That means the wound morbidity would be very high. So if you already have a division of zone 3, it's better to utilize the same zone incision so that the further compromise in the vascularity can be avoided. And the important area with the nerves is all the nerves run between the internal oblique and the transversus abdominis. So that is a plane which we should not breach in any of our surgical techniques. So when we talk about extraperitoneal spaces, you can see there are so many various layers which are available where we can place a prosthesis. So one commonly performed in open is a onlay repair. Then you have something called as a inlay, which is basically a bridging, in which where you're not able to bring the fascia together, then you can put a heavyweight mesh in between to bridge. That is the last resort. You don't do it as a primary option. Then the most attractive option right now is the retrorectus. So here you can see the mesh in a nice sublap fashion. It's a good vascularized area as well. So that gives you a good durability if you can perform it in a safe manner. Then you also have the preperitoneal plane, where you can do something like a TAPP for ventral hernias. And then of course intraperitoneally you have the IPOM. So pretty much majority of our interest right now is going to be in the retrorectus or the preperitoneal area, because onlay we know that the wound morbidity is very high, and also the complications and the physiological principle, it doesn't comply with the Laplace law. So the chance of a recurrence is much higher. So we are not going to talk much about the onlay. So we are mainly focusing on the sublay or the preperitoneal repairs in this applied anatomy talk. So when we talk about the retrorectus, you can see the Reeves stopa, ETEP Reeves stopa, TARM or Milos. All these techniques utilize the same plane. So it is basically a different way of doing the same procedure and placing a prosthesis in the sublay plane. And when we talk about pre-peritoneal, you have a TAPP or a lap pre-peritoneal repair which is available to you. And intraperitoneal, I'm sure all of you know, and majority of you would be probably utilizing it as well, the IPOM plus. So we'll look at a little bit of the cross-sectional anatomy and how each of these layers are contributed so that we have a better understanding. So we have 2 rectus abdominis muscle on either side, and then you have 3 flat muscles on the each side. So one is the external oblique aponeurosis, which is the outermost flat muscle. Then you have the internal oblique aponeurosis, and then you have the transversus abdominis muscle. So what happens is all these 3 muscles would contribute to form the rectus sheath. So the TA muscle and the posterior lamella of the internal oblique, they join together to form the posterior rectus sheath. Same way, the external oblique aponeurosis and the anterior lamella of the internal oblique, they join together to form the anterior rectus sheath. And both the anterior and the posterior rectus sheath will join together to form the linea alba. And these junction in the lateral side is the linea semilunaris. So now you can understand better how this retrorectus space is a single identity, and here this retrorectus space is a separate entity. So in order to combine these both, you will have to do some maneuver to combine it into one retrorectus space. So that is what is called as a crossover. Again, I'll show you a pictorial representation so that you can understand it better. And then you have the peritoneum, which is seen in the umbilical level. When we go to the infraumbilical level, what happens is you don't have the posterior rectus sheath, so that is deficient. All the 3 muscles contribute to the anterior, and there's only a anterior rectus sheath. And the transversalis fascia becomes much more prominent in the lower abdomen, and it is easily identifiable and dissectable as well. So that kind of acts as a buffer to protect your peritoneum so that you don't cause multiple small buttonhole injuries in that. So when we talk about anterior component separation for a large hernia, what we basically do is we incise the external oblique lateral to the linea semilunaris, and then you dissect a space between the external oblique and the internal oblique. Because as I was alluding earlier, you have the nerves which are running between the internal oblique and the TA muscle. So we do not want to go into that plane, that will injure the nerves. So now you dissect this space, and this will give you a good advancement of the anterior fascia. You can do it either unilaterally or bilaterally depending upon the size of the defect and the extent of mobilization you would require. And a small anatomical change which I want you to identify is all the lateral muscles, they don't stop in the lateral one single line. If you look at the transversus abdominis muscle in the upper abdomen in this CT image, this is the rectus abdominis muscle, and you can see almost the lateral 1/3 of the rectus abdominis muscle. Below that you have the transversus abdominis muscle. So this is an anatomical landmark which is very important for us when we are doing a posterior component separation. So you can divide and incise the TA muscle much more medially in the upper abdomen, and you should gradually go lateral. Or if you're coming from bottom up, then you should curve your incision like a hockey stick. Start from the lateral aspect and come more medially. So again, now this is a very recent presentation in December 2023, and you can see very clearly again, this is the 2 lamellas of the internal oblique and how they contribute to cover the muscle. So this is the TA muscle, this is the internal oblique, and it is splitting into an anterior and a posterior leaflet. This is the rectus abdominis muscle, and this is the external oblique contributing. Both these 2 combine together to form the anterior rectus sheath. Both the TA and the internal oblique contribute to form the posterior rectus sheath. Same anatomy on the opposite side. You can see a nice bulky rectus in this cadaver, and you can see the TA muscle contributing along with the posterior lamella to form the posterior rectus sheath. Here the external oblique and the anterior lamella to form the internal oblique. So all these anatomy are present, it's just that we haven't been giving a lot of importance to them, and now we understand why it is important in our applied anatomy and surgical practice. So when we talk about the linea semilunaris, the yellow line, you can see it is not a straight line. As I was showing you in the CT scan, the transversus abdominis muscle comes much more medially in the upper abdomen. Whereas as you come laterally, it becomes much more thinned out. It's more of a fascia, and it goes a lot lateral. So what anatomy we see in our surgical practice is not only the linea semilunaris. There is a new terminology now which has come into, it is called as the ambivium. Basically the confluence of all the 3 lateral muscles. I'll show you in an intra-op image as well so that you can understand it better. So you can see this is a single line, which is the ambivm, which is a new description. And the linea semilunaris, you can see how it is becoming crescent shaped and moving across. So here you can see the TA muscle also very clearly. So if you have to do a component separation from the superior aspect, you can just divide this muscle and go into the TA plane. Whereas posteriorly it would be a little different. So this is why this anatomy is very important to us. So now if you have to do a posterior component separation, what basically we have to do is, first you will enter into the retrorectus space and dissect it. Then you will divide the posterior lamella of the internal oblique, and then you will divide the TA muscle. So first we will incise the posterior lamella of the internal oblique so that the TA muscle becomes exposed. Then you would incise the TA muscle, and now you create a plane between the TA muscle and the preperitoneum or the preperitoneal pad of fat. So this is the nice plane which you can dissect almost up to the retroperitoneum, beyond the psoas muscle on one side. If you do a bilateral TAR, then you can do the same thing on the opposite side as well. So when you are doing something like a E-tip reef stopa, what basically we do is, if I am a right-handed surgeon, I enter into the left retrorectus space and I insufflate it with CO2. And once I have dissected a little bit of the retrorectus space and made my working ports, now I have to incise the rectus sheath on the left side. So that is incised. Once I do that in the upper abdomen, my falciform ligament gets exposed. Then you dissect the falciform ligament down and you see the linea alba. And now once you dissect to the opposite side, you will have the retrorectus space and the rectus sheath on the opposite side. Here again you incise the posterior rectus sheath, and now you can see we have connected both the retrorectus spaces and it has become into a single large retrorectus space. If it was a moderate sized hernia, just a reef stopa would be good enough. But if it was a larger hernia, then we would do a component separation. Thank you very much for your patient listening.
Very important, very basic, with a very nice illustration, and most of the you have made the concepts clear. Thank you very much.
Thank you.
Have the question at the end.
So next I'd like to invite Dr. Sashri Paudel. He'll be talking about finding hernia, understanding abdominal wall imaging.
Okay, my first topic will be finding hernia, understanding abdominal wall hernia. Okay, I'll be talk about briefly about inguinal. It's about the ventral hernia session, but I'll just talk briefly into inguinal hernia and just basically when to use imaging. And on the ventral hernia, I'll be talking about what information you gather from the imaging. Okay, so international guideline from groin hernia. It's just like the history and clinical examinations are all that you need for the diagnosis of clinically evident groin hernia. If there comes to the bulge, it presents the typical symptoms like it's when you are lying down, it goes around, and then with the persistent, it comes out. So if it has all the classic symptoms, you don't generally need any imaging to tell us that that's a groin hernia. So it's actually a gold standard, but it will be required when there is like you have a vague groin swelling and that's uncertainty. Sometimes like the patients do come, they think they have swelling sometimes, but when he presents in the clinic with your OBD, he does not have the swelling, and then the localization is also not very well localized, and the swelling is intermittent, and also there are other groin complaints without swelling. In these cases, imaging is going to help you. So what imaging techniques we have? Like, as I said, clinical examination is a gold standard for diagnostic of clinically evident groin hernia. It has sensitivity of 0.74 and specificity of 0.96. One of the best options you have is the ultrasound. It is non-invasive procedure. You don't have any radiation involved. It's a very easy to do and economical, and you can even do it in the real time. So if you have access to ultrasound, you can do it yourself, and then you can ask them to give the pressure, and then you can even you can check even if in the recurrence, even if it's a mesh there, you can find the mesh. It has a sensitivity of like depending on the study, 77 to 82%, a specificity of 86 to 95%. but it is user dependent. If you don't know how to use ultrasound, and like it differs from people to person. So if you are a good ultrasound, you can do a good ultrasound, you have your chances of finding it is better. And CT is another option. It's in Japan, like CT is like it's very easy to do and it's not that costly. So one advantage we have in the CT that the ultrasound does not give us is it can also be used as a general screening. You can screening for other pathologies. Like it's around the chances of finding other pathologies are 1 to 2%. So whether you say it's like it's high enough for or low, too low, it depends on your it depends from people to person, country to country, whether it's cost efficient or not. Like I personally have found like advanced, I have found gastric cancer, pancreatic cancer, lung cancer during my CT for the inguinal hernia. Okay, so the evident thing, the disadvantage is a cost, radiation is involved. But if you are going to do a CT examination for hernia, inguinal hernia, it's best if you do it in a prone position, because in the supine, like the sensitivity increases when you do the hernia, the CT examination in the prone position. And MRIs also is the cost is obviously there, but it can be used in differential diagnosis of the vague inguinal pain. And then also if you are using MRI for inguinal hernia, it's best like dynamic MRI with the valvasa, so when they put on the pressure, it's better. And another thing is herniography. It's very rarely done. I have never seen anything done. It's something like this. You just insert a contrast medium. It used to be done like there is only 1 or 2 surgeons in Japan that's currently do that, but I don't think it's worth all the hassle, but it's still there, one of the ways. So an inguinal hernia, like I have few cases that helped me. So this one is one case. So here you can see that it's it has a lot of fat, no bowel. So it also can help us like identify pre-operatively, gather information if there's a lipoma or not. Okay. So I take this for the operation, and then like I'm just dissecting here. It's a lot smaller hernia than what is clinically evident, and then after dissection, I see that, okay, even without the CT, probably you diagnosed as a lipoma here. But I can, with the CT, it will, even if for the beginner, you'll know, okay, the lipoma is going to be a large one. Okay, so you can just go on and it will help us. So, and then you just take the lipoma out here. So this lipoma has been sliding up and down. So you cleanly take the lipoma out. And for the, like Dr. Mani said, like you don't always need to take the lipoma absolutely out. You can leave in the preperitoneal space if you adequately dissect, and there is you have a something to, if you have just the mesh, you place the mesh between the lipoma and the abdominal wall. Another case, this one was an interesting case. Like this one also I have a CT here, and I can see, okay, I suspected, okay, there was a lipoma here. And then when I go for the tap, you can see, you see, okay, there is no bulge there. So if you don't have a CT and then you just clinic examination, and you are not sure about what to do in this, you may just come out doing nothing. But like, because I have the CT, I can recheck the CT. I know, okay, there is a lipoma there in the direct space. So after dissection, okay, I'll just forward. After dissection, there's actually a lipoma that's okay. So there's a hole here. Just a minute. There's a hole here that the lipoma was going in. So I repaired it. Repaired it with the mesh, the usual tap procedure. And also, it's also useful when you have like the recurrence, or like sometimes like this one we didn't do the pre-operative CT, and this one was actually my resident's case. The repair was done, tap repair was done, but the bulge is not gone. And then we took him to CT, and then like we had not, like Dr. Mani said, so it was another earlier cases. So we had left the lipoma there, and then like the symptoms had not. And then if you look at the CT properly, so if you look at the CT properly, like even the direct, like we had done nothing. We just have taken them and given him GA and pushed a mesh and come. So it was not repaired. So we did the open repair. We took the lipoma out and we repaired again. So and the recurrence, and if the things does not go plan, like CT will give you a lot of information in these sort of cases. So about ventral hernia. In ventral hernia also, like for the diagnosis, it says that most of the ventral hernias are easily diagnosed based on the clinical examination. So you don't need, according to the guidelines, you don't need imaging to diagnose clinically evident. But I don't know any ventral hernia surgeons that will go to the operating room without a CT, at least on any imaging, because preoperative and like it's not just about diagnosis. You need to gather as much information, especially if it's an incisional hernia. If it's a small umbilical hernia, just a primary ventral hernia, there's no more surprises, but we want to avoid as many surprises as possible. So according to the guidelines, the preoperative abdominal CT or abdominal ultrasound may be considered for select patient with suspected ventral hernias to confirm the diagnosis. But I think the main aim here is to aid the surgeon with the preoperating planning, like what size of mesh you want to use. If you want to go further, do you need the component separation or not? Like these sort of things all comes. Like this is one of my patients. Like if this patient comes and okay, this is a clinically evident ventral hernia, will I go into operation room without a CT? I don't think so, right? So what do you assess in the hernia, ventral hernia? One of the things that is we want to assess the location of the hernia. We want to and then the size. So according to the guidelines, the sizing of the hernia orifice is recommended. You do it with the preoperative CT, and also the content. You want to check what the contents there, and you also want to check how the abdominal walls, like the rectus muscle, what are they and what type of what is the quality. Like here you have, like in the right sided rectus muscle is a very quite healthy rectus muscle here, but you see that like the left sided it has been destroyed, so you just have some rectus muscle there, right? And also if it's umbilical hernia or something, you can also check if this diastasis recti is present or not. Sometimes you repair the umbilical hernia and then if they come with the bulge in the diastasis recti position. And also you want to calculate the loss of domain and effect of previous surgery. So the CT has been advanced, and like 3D rendering is also possible. So this also gives us a visualization, just the axils like the CT. It helps us visualize the hernia better, and you know the location of the hernia sac and the also position, and also it will help a lot in the preoperative planning. And also abdominal wall, like I said, presence of muscles and location, quality, and the width. So this will help us determine if we need to do the component separation. So this one concept is rectus to ratio defect. This will help us plan preoperatively if you need to have a myofascial release like TAR or component separation. So rectus, if you calculate the width of the rectus muscles, both the rectus muscles, and we calculate the width of at the largest diameter, you have the diameter of the hernia. And if the rectus to defect ratio is less than 1, is more than 1, then it needs more than 78% required. It's more than 1, it's required myofascial some component separation. And if it's If it's say less than 1, it's required. If it's more than 2, then only 10% of them required. So they even calculated the predicted. So if the cutoff point was 1.34, so if it's with that, if it's less than 1.34, you will be probably requiring myofascial release. So probably go for TAR or anterior component separation. There's a high chance that you will require it. Another thing is, especially in ischial hernia, you don't need to worry about. But if it's a huge hernia, one thing you need to consider is loss of domain. So because like one of the risks of repairing a ventral hernia, especially large one, is you can create abdominal compartment syndrome. Right? So the for that, like there are actually 2 index that's widely used: Tanaka index method, and this is the Saba index. So recently the guideline came, and this was chosen by the experts, the hernia experts around the world, to be the better option. So basically you calculate the volume of the hernia sac volume and also abdominal cavity volume. So Tanaka index, we just there is the ratio between the hernia sac volume and abdominal volume. But for the Saba method, it is hernia sac volume and total peritoneal volume. So it's abdominal cavity volume plus hernia sac volume. If that ratio is more than 20%, then like there is a high risk of abdominal compartment syndrome. So you need to have some sort of preoperative tissue expanders. Like you need to either use Botox or peritoneal PPP, right? So progressive pneumoperitoneum, preoperative pneumoperitoneum. And like these are the hernia, these type of hernias. If you have a loss of domain hernia, if you are still a beginner, if you have just tried few cases, 10-15 cases, this is not the hernia to these are the hernias that needs to be addressed at the center of excellence. Okay? So also affect the recurrence is ventral hernia itself is a challenging case, and recurrent ventral hernia is more challenging. So in this, like the CT can also show you where the previous mesh is, and where the plane of dissection had happened, and what type of adhesions you have. Like if you are planning for like laparoscopy, where you will put your first boards, like you can use these CTs and ultrasound to guide you with that one. So this is a clinical management of hernia clinic. So it's not that you need like the CT, the preoperative CT is a must, especially in huge case, complicated cases. And it's not that you have one CT and then you if you are going the patient, you are putting through rehabilitation and you're waiting for the patient to get stronger, better, then it's and there is a huge gap like that. This tend to change, so it's best to have a CT that's nearer to your surgery date. So my take-home message is like imaging can be imaging is for diagnosis. It may not always be must, but it can be a useful tool. It's a very powerful tool to make sure that you have fewer surprises during your surgery. Thank you.
Learn to read the CT scan, especially for complex ventral hernias. Thank you, Dr. Sasim.
Thank you. I would like to call upon the next presenter. Is Dr. Suresh Prasad Sai. Probably everybody knows him. He's an additional professor and the head of Department of General Surgery at BP Koirala. And he'll be presenting on mesh review, where we are in 2024.
And delegates from different parts of this country. On the behalf of Department of Surgery, I would like to welcome you, all of you, in this small city of eastern part of Nepal. So I'll be talking about the mesh reviews and where you will be after in 2024. So mesh review. Mesh is a medical device that is used to reinforce the weak tissues in various procedures, And with the use of these meshes, there are the different meshes, there are intense debates as recent updates have focused on safety concerns of mesh. So as you know, the mesh use of mesh occurred in around 1800 century, and after the Second World War, there was a discovery of synthetic polymers, and then there was in 1935, Wallace Schwimmer first discovered this mesh, synthetic polymers, and in 1958, the monofilament polypropylene mesh was first discovered. So continuing this, initially there was a meshes of polypropylene, polyester, and expanded polytetrafluoroethylene, and then later there was a meshes of polygalactine cellulose and omega-3, titanium, collagens were used as additional materials. In 1998, Dr. Pazotti first introduced this three-dimensional mesh, and these three-dimensional meshes are anatomically designed, it has a easy positioning, fixation-free, and there is a less pain in three-dimensional mesh. So I will be just talking about what are the recent uses of mesh. As you all know, the hernia surgery is the most common, and there is a estimated cost of around 48 billion per year in US states only, the cost of hernia mesh. And there are other uses, like you can use this hernia mesh in pelvic organ prolapse also, on stress incontinence surgery also. But there is a limited use of this. There is a increased scrutiny and controversies in the uses of mesh uses in pelvic organ prolapse repair, and so that's why the use of this mesh in pelvic organ prolapse repair has been limited, and alternative techniques have been preferred nowadays. In breast reconstruction also you can use mesh, like this matrix of the implants can be held by the use of sealing of mesh, and there are newer lightweight meshes that can be used in the breast, in breast surgeries, breast reconstruction surgeries. In wound healings also you can use mesh. These are biocompatible meshes. So these are biological meshes can be used to cover the wounds for better healing and promoting faster healings. So these are the common uses of mesh, surgical meshes. So what are the available surgical meshes, commercially available surgical meshes? There are more than 70 meshes available in market. However, it is difficult to find even today. It is what is the standard mesh, or which mesh fulfills all the criteria, the ideal characteristics of a mesh are not achieved. So according to the composition or type of material, the meshes are classified as first generation mesh, second generation mesh, and third generation meshes. These first generation meshes are synthetic non-absorbable meshes, and in second generation also there are mixed or composite meshes. Third generation, you can see there are biological meshes are third generation meshes. So in first generation meshes, the companies like Otto Sucher, Ethicon, Marlex, they have made meshes of polypropylene and bicryl meshes of polygalactine. So these are synthetic meshes of one material only. And Gore-Tex, these are the first generation meshes. In second generation meshes, there are combination of polypropylene, polyester, or extended polytetrafluoroethylene in combination with each other, or in combination with other materials like omega-3, titanium. So these are second generation meshes like Bipro, Gore-Tex, Paratex, and Tie meshes. These are second generation mesh. And composite mesh is also a second generation mesh. And this requires a specific consideration when you place intra-abdominally. Visceral side has a micro surface that prevents visceral adhesions, whereas a non-visceral side has a open microporous to allow parietal tissue ingrowth. So, and these meshes may require hydration during placement. And if there are two parts of these meshes, one that is fixed to, that is synthetic part that is fixed to the parietal wall, and later that provides the mechanical strength to the abdominal wall and promotes collagen ingrowths. And the peritoneal side mesh has, it may be natural or it may be synthetic. It degrades on its own and avoids adhesions to the viscera. So this biological meshes is the third generation meshes, as I said, and it has it is made up of basically porcine dermis or porcine small intestines of mucosa or bovine dermis or pericardium, and the dermis or fascia or fascia lata of cadaveric human. And these biological meshes they have different uses in hernia, mostly in contaminated hernia repairs. So there are three types of biological meshes available. The one is a acellular matrix, another is a xenografts and composite meshes. So acellular matrix are those derived from porcine dermis or small intestine of porcine, and the cellular parts of the component are removed. That's why it is called acellular matrices, and that contains natural collagen and elastin structures are there in acellular matrix. And then xenografts that are constructed from human cadaveric tissues like fascia lata or from pericardium of cadavers. And composite meshes, they are both biological components as well as synthetic components to offer both tissue integration and mechanical strengths. So these are composite meshes made of biological components and synthetic components. These are some of the examples of this composite biological meshes. One is sargisis, alloderms. These are commercially available biological meshes. So the advantage of biological meshes are it has a better tissue integration, and because there is a reduced inflammation in less inflammation in and better tissue integrations in biological meshes. And but the cost of this biological meshes is very high, and it has a low mechanical strength you see in biological meshes, and there is a long-term inconclusive data are not there for this biological meshes. On the basis of porosity and mesh weight and density, in 1971, Amit et al. Classified the mesh in microporous mesh of size more than 75 micrometer, and microporous when the size is less than 10 micrometer. And there are other meshes like microporous or microporous with multifilament components, and prosthesis with submicronic pores. These are silastic meshes. And on the basis of mesh density and weight, the mesh have been classified into heavyweight mesh more than that. The weight is more than, when the weight is more than 140 gram per meter square. Standard weight mesh when the weight is between 70 to 140 gram per meter square. And lightweight mesh, when you say a lightweight, that means the weight is 35 to 75 gram per meter square. And ultra lightweight mesh, when the weight is less than 35 gram per meter square. There are few meshes that elutes the drugs that you can combine these drugs with the mesh, like vancomycin, rifampicin, gentamicin, and these are few drug-eluting mesh implants. So I will discuss few of the studies of this biological versus synthetic meshes. These are meta-analysis of 4 randomized control trial, and in this study 632 patients were included in the meta-analysis, and that's what this synthetic mesh compared to synthetic mesh, the biological mesh resulted in increased hernia recurrence, but the rate of seromas, hematoma, and mesh removal were similar in both the groups. Another analysis, that was a comparison of outcome of ventral meshes using different meshes. In these studies, there was 32 studies, 23 studies involving 2,603 patients were included in the study, and the study results were there was no differences between mesh in recurrence at 1 year follow-up, and even there was no difference in surgical site infection. And in this, there was non-cross-linked bovine acellular dermal matrix was associated with lower recurrence rate and surgical site infection rate, and this non-cellular, non-cross-linked human acellular dermal matrix was associated with the low seroma rate formation, lowest seroma rate, and porcine submucosal intestine, small intestine submucosa has a higher risk of seroma than non-cross-linked human acellular dermal matrix. There is another study, there is biological versus synthetic mesh for single stage hernia repair. And in this randomized control trial, 253 patients were randomized to synthetic mesh and 127 patients in synthetic mesh 126 and biological mesh 127. And this study was followed for 2 years. The findings of the studies was in synthetic mesh was significantly reduced. In synthetic mesh, there was a significant reduced risk of hernia recurrence compared with biological mesh in patients. And the synthetic mesh even can be used for contaminated ventral hernia. And both meshes demonstrated similar safety profile. But the price of this synthetic mesh, this biological mesh, was over more than 200 times than the price of the synthetic mesh. These financial aspects of surgical mesh I have tried to show. This mesh utilization is associated with higher direct costs, and on top of that, this biological mesh adds significant costs and should be thoughtfully considered when utilizing these materials. In this slide, I try to show the ideal mesh requirements, and this should be there. The mesh should have longevity. It should have a biocompatibility, convenient handlings, low risk of infection rate, and socio-economic considerations. That means easy sterilization, easy manufacturing, and low cost of this mesh. So these are some of the ideal characteristics of mesh. So, in current research on surgical meshes, most surgical meshes are currently chemically and physically inert. They are non-toxic, they are stable, and they are non-immunogenic. However, none of them are biologically inert. Hence, the area of study research focuses on inflammation and wound healing. So, and there are newer alternative techniques, that is novel coatings on the mesh, coated mesh, and integration of nanofiber and nanotechnology based mesh are coming up, and extensive research focuses in the development of bilayer composite mesh. Bilayer composite hernia mesh is another. And then this variety of biocompatible and biodegradable natural and synthetic polymers are being investigated for this further studies. This nanotechnology and nanofiber mesh they are coming up. In this, we can small things are seen bigger. You know? Nanofibers, like you can cell to cell changes, and then better mesh can be made by using this nanotechnology, and better meshes, nanofiber meshes are being in the process of research. And this possesses higher porosity and small porous size. And these properties make nanofiber systems suitable for biomaterials and in wound care, drug delivery, scaffolds for tissue regeneration. And commonly used nanofiber materials are polycaprolactone, polydioxanone, polyethylene. These are the nanomaterials used. So here you can see a nanofiber. This nanofiber, when you see this nanofiber technique, you can see the mesh. Here is the this mesh is there are two. This is a two-layered mesh. One is dopa, and another side there is a polycaprolactone. Another side there is a dihydrophenyladenine, and this is a normal view. And this is a nano. After using nanotechnology, this nanofibers. And this the future mesh, I think. And there are other modifications in mesh can be made by doing this coating, spraying, 3D printing, electrospinnings, and chemical reactions. These are the newer modifications in mesh are in progress. And this new generation mesh, one is this polypropylene mesh with antimicrobial benzoyl chloride induce proliferative activity of fibroblasts. This treatment of polypropylene with 0.2 to 0.05 bax dilutions, that is benzoyl chloride solutions. And these results are promising due to the ability of these antimicrobial meshes to prevent infection while leading fibroblast proliferation. So a few lawsuits about this mesh. There are thousands of women have filed lawsuits around companies alleging serious complications like chronic pain, erosions, and organ damage. And these lawsuits continues with recent settlements on upcoming bellwether trials expected to impact these future litigations. In January 24, Ethicon and Johnson & Johnson quietly settled 224 hernia mesh cases in multi-district litigations. In October 2023, also the third bellwether trial against Bard Company for hernia mesh hernia, scheduled to begin in the U.S. Court of Southern District of Ohio. in April 2023 also this FDA they advise that the surgical mesh for transvaginal pelvic organ prolapse repair should demonstrate superiority over native tissue repair at 30 months to be considered favorably. Then only you can apply this surgical meshes for pelvic organ prolapse. And the conclusion is for today's talk is the search for an ideal mesh will never end. Hence, it is paramount that the goal of the search should maximize patient benefits, and researchers should focus attention on the development of prosthesis which will withstand disruptive forces, minimize contraction, be durable, compatible, and also produce a suitable biological response. And adequate audits both at hospital and government level agencies are conducted so as to avoid violation of patient safety and care.
The journey of mesh from development to the use of nanites. We'll take the questions at the end of the session.
Okay, to continue the session now, I would like to call Dr. Ashwin Thangvelu to present his topic on laparoscopic ventral hernia repair, tips, tricks, and modal modification.
I have mentioned only IPOM pluses. I feel that IPOM is almost obsolete because we know with the recent study that IPOM plus definitely yields better results. So immaterial of the size of the defect, it's better to go with the closure of the defect. That reduces your seroma. At the same time, it gives you a nice interface for the mesh to integrate into it so that the overall good results can be sustained for a longer period of time. So IPOM per se is a misnomer. It's not an onlay repair, it's more of an inlay, underlay repair. So it's an IPOM rather than an IPOM. So when we talk about IPOM plus, the definition mainly how it varies with the conventional IPOM is that you close the defect in an IPOM plus. So what are the indications? So any procedure now has limitations. You can't say that one procedure would fit into any of the characteristics. So IPOM plus comfortably in a majority of the patients up to 6 centimeters I think is a reasonable defect size which we can consider. Predominantly for midline hernias. When it is an atypically located hernia like a subcostal hernia or a lateral hernia, then sometimes the fixation of the mesh becomes a challenge. So that is a major drawback and a limitation if you're considering a IPOM plus. Then it's a very good procedure in high risk patients where you can't do a very prolonged surgery, you want to go quickly in and come out, then IPOM is a very good procedure in those scenarios as well. And even though we are moving towards other procedures saying the negatives of IPOM, IPOM turns out to be a salvage for a lot of these newer procedures as well. So that means you still have a role for IPOM and it's not completely out of the picture, at least yet. And it's a straightforward and a quick procedure. Even someone early in the learning curve can perform the procedure very competently if taught the right way. The skills required are much less compared to any other procedure because even if you're very average in your suturing skills, you can still do a very good IPOM because a lot of the fixation of the mesh is going to be dependent on mechanical equipments like tackers. The learning curve compared to other ventral hernia procedures are much less, and it's easy to quickly master the procedure and get very good at it. And the anatomy is very familiar to a conventional laparoscopy, so you do not have some new anatomy like a retrorectus space or an extraperitoneal space where you have to learn and relearn the anatomy once again, whereas this is something which you would do day in and day out. You would do your cholecystectomies and appendix by entering into the abdominal wall. The disadvantages which many people quote: one, it is very expensive because you need a special mesh. You can't use a uncoated polypropylene mesh. So you depend on a special mesh with a special coating so that the additions to the polypropylene material can be reduced a great deal. So that makes the mesh, and that portion of the mesh is never going to integrate into the tissue. Whereas if you do a closure, then the defect integration also is way better. And once you reduce the contents, that doesn't mean you're ready to place the mesh. You still have to make a few preparations before you can place the mesh in an adequate manner so that it comes directly in contact with the fascia, which means it will yield more strength for the repair and durability for the repair. So the first thing is to take down the bladder flap lower down so that the fascia is totally exposed, because in certain patients the amount of fat you see over there is quite a lot, and if you're using a fixation device it only penetrates to a few millimeter, which will not be adequate if it doesn't go to the sheath. Then that means it's just floating around in the fat. The same way you have to take down the falciform ligament as well. A lot of the times it will look like very thin and fused up falciform, but once you dissect it you will appreciate how much of thickness of fat is there. And after that you can place a mesh, and again no uncoated polypropylene mesh, that's a definite no. And you have to use a dual mesh with a special layer. The size of the mesh, how to decide. So now we don't talk about the overlap in terms of centimeters. It is better to talk in terms of a mesh defect area ratio, and it's very simple. You just have to take the defect, the width of the defect, and multiply it by 4 for you to know what kind of a mesh would be optimum. So say a 4 into 4 centimeter defect would warrant a 16 into 16 centimeter mesh, so that your ratio is less than 16, it's more than 16 and gives you a good durable repair. If it's less than that, then that means your recurrence rate